For the next talk, I would like to invite Dr. Devesh KUMAWAT. Dr. Devesh KUMAWAT is alum of prestigious RP Center AIMS, New Delhi, and he's currently working again at RP Center, and he's going to talk on mastering Okta, interpretation, toolkit, and addressing the artifact. Over to you.
Good morning, everyone. Thank you, Dr. Ankur, for the introduction. So I'll be talking about the basics of OCT angiography. How do you interpret and how do you take care of the artifacts, which are very common in OCT angiography. So OCT angiography, as you all know, is a dialysis angiography in which we acquire and analyze the en-face images of the retinal as well as the choroidal microvasculature in a depth-resolved fashion. That is, you are able to segment the individual vascular layers, the superficial plexus, intermediate, deep plexus, choriocapillaries, and the choroidal stroma. You can segment them in a depth-resolved fashion, and that prevents the overlap of the vascular structures. Unlike in fluorescein angiography, where you are not able to analyze the deeper structures, you are mostly able to analyze the superficial vascular plexus in the retina. Here you can analyze all the layers of the vascular plexus. Now, since there is no dye which is used in OCT angiography, so there is no leakage. So OCT angiography images will be will have very high contrast, and because there is no image, there will be very less obscuration of the underlying vascular details. Another important benefit of OCT angiography is that it doesn't require any dye, doesn't have any side effects, can be done very quickly, and can be repeated in patients those require repeated imaging, unlike fluorescein angiography, which can have its side effects and contraindications and is not routinely done on successive follow-ups. Now, what is the principle of OCT angiography is it's based on the decorrelation signals. What do you mean by that? So in this, there are successive images are taken, B-scan images are taken at a particular point in the retina or the choroid, and what is the signal that is coming from these two images? The detector detects the difference in the signal from these two images at the same place. So there is a decorrelation signal that is detected by the detector, and then this decorrelation signal, the machine interprets that it is occurring because of any movement within the structures which are captured by the B-scan. So since retina, choroid, and the eye is not a movable structure, otherwise the internal structures are not moving, so what is moving is the blood. That is the blood flow, it is there, the RBCs are moving. So that decorrelation signal is occurring because of the RBC movement from one place to another in the same B-scan image, which is taken at very short intervals. So that gives you a decorrelation signal, and eventually the machine creates a decorrelation map which shows you the flow of blood. It's not the vessels, it is the flow of blood which is shown here. That is the blood column that is moving, the RBCs which are moving. So it is not the vessel wall which is seen here, it is the vessel blood flow which is seen within the vessels. Now, inter-scan time is very important in OCT angiography. So basically you are taking successive B-scan images which are separated by a very short inter-scan time. Now, if the if the blood flow is very rapid, so the RBCs will move out of that B-scan image very quickly unless you have very short interspan time. You need to have very short interspan time so that successive B-scan images are taken when the RBC is moving from the first red dot to the second red dot. But then the RBC should not move out of this B-scan image also. Otherwise, the flow will not be detected. So very short interscan time is required for higher blood flows. Higher blood flows require very short interscan time, and very low blood flows, if there are very low blood flow, suppose in a microaneurysm or in a polyp, then you need to increase the interscan time, because the RBC movement from one place to another will take a lot of time when the blood flow is slow, and therefore your successive B-scan images should be separated by a longer interscan time. So what is the problem? You can increase the interscan time to a very long thing, but then there comes the eye motion and artifacts arising because of that. If you increase the interscan time, the total scanning time will increase and the eye movements are going to happen, and that will lead to motion artifacts. So that's why most of the machines do not allow you to change the interscan time, and they have a preset interscan time that allows minimum artifacts and maximum flow that could be captured. Now, there are two parameters that could be detected by the detector. One is the amplitude decorrelation, that is the amplitude difference in the light that is coming from the two successive B scan images at a single place, or it could be the phase difference. So it could be either amplitude difference or phase difference that is captured by the machine. Now signal is basically the flow that you are seeing, and noise is anything that is interrupting. It could be a cataract or a media opacity, or poor tear film, or it could be a poor image acquisition that could be there. So there are certain methods to improve this signal noise ratio, and these are the various methods: split spectrum, speckle variance, and volume averaging. You might come across these fancy names, but what they do is that they increase the signal to noise ratio. Now there are different commercially available platforms which are there. I have no financial interest, but the common ones are mentioned over here: AngioView by Optoview, then Angioplex by Zeiss, Spectralis by Heidelberg, AngioScan by Nidec, and SSOCT Angio by Topcon. Now SSOCT is the last one. The Topcon is the swept source based, and the rest are the SDOCT based. Now all of these platforms will have their own default layer segmentation. So you cannot compare the images which are taken on different machines of the same patient. You cannot compare them. These machines have different resolutions, different scan areas, and different default layer segmentation. Now, as I told, majority of them are the spectral domain OCTs, in which you have a wavelength of 840 nanometer superluminescent diode is used as the source of light, whereas in swept source OCT based machines, you have a tunable swept source laser which is there with a wavelength of 1050 nanometers. So what is the difference between the swept source and the spectral domain OCT angiography machines is that because of the longer wavelength, your choroid gets imaged better, but the resolution more or less is the same. And the swept source machines have a faster A-scan acquisition. So more A-scans are being acquired in a given time. So the resolution of the images, that's why it could be better. Or you can image a larger area in the same given time also. Now scan size, as I told, so on the left you have a 3 mm scan size, and the right you have a 6 mm scan size. So scan size affects the resolution of the images that you get on OCT angiography. In the left, if you see a 3 mm scan, in the same time you have more time to achieve a higher resolution. More A scans could be done in the 3 into 3 mm scan, and while in the 6 into 6 mm scan, the A scan values are less, so the resolution will be a little less. Now, how do you interpret an OCT angiography when you have an image which is there on the machine? Now you have to interpret it. So you don't only look at the different NFAS OCT images, there are different slabs that could be there. Commonly you have the superficial vascular plexus, then the deep vascular plexus, then you have the avascular zone, and then you have the choriocapillaris. Now here in this image you have a full retinal scan wherein the superficial and the deep and the outer retina, they have been clubbed together. Then the second image is the superficial and the deep have been clubbed together, and then the second image is of the outer retina, and the third image is of the choriocapillaris. Now you not only look at the NFAS OCT images, you also look, as Dr. Vinod had told, that you also look at the B-scan images in conjunction with the OCT angiography images, because you need to have a look at the segmentation, whether it is done properly in these images, and also at the flow signals. So you have down in the bottom, you can see that there is some flow which is seen below the RP level. And then you see in the choriocapillaris slab, there is a network of vessel. So now you have more confidence that yes, it's an abnormal network which is there, which has a flow on B-scan image, and the B-scan image is also taken from the right area. Now you also need to look at the structural NFAS intensity image, because I'll come to that later on, but you need to have a look at the intensity, whether the image has been properly acquired or not, whether there are any artifacts which are coming in it, whether there are shadow artifacts which are being misinterpreted as flow void areas. So that is why you need to have a look at all three images: OCT angiography, NFAS images, B-scan with flow overlay, as well as segmentation lines, and the intensity image. Now, broadly speaking, the utilization of OCT angiography lies in detection of the macular neovascularization and characterization of that. And then you have the capillary non-perfusion or the flow void areas that you want to assess. So this is the qualitative assessment, and then in proliferative retinopathies, you can have you can use OCT angiography as an alternative to fluorescein angiography for assessment of early neovascularizations. And last, which is an important benefit over fluorescein angiography, is that you can perform a quantitative assessment of the vasculature as well. Now, important here is that you need to know the artifacts which could occur with OCT angiography, and you need to interpret accordingly and take care of all these artifacts before you come to a conclusion. So motion artifacts are very common, and they happen because of the gross eye motion that happens during the scan. So there are ways by which the machine compensate for it. So one of them is the eye tracker, that the machine stops the scan when there is an eye movement and then resumes it when the eye achieves its normal position. And then machine can rescan the affected area. So the affected area could be rescanned again, and then it could be incorporated in the original image. Another important software correction is also there in the recent machines, in which you have the machine acquires horizontal as well as vertical raster scans, and then it see how much is the displacement of the image occurring in the successive phase, and then it corrects for that displacement based on these vertical and horizontal raster scans. Next, projection artifact is very important because it will lead you to make an erroneous diagnosis of an abnormal vasculature in the deeper slabs. So it is also known as decorrelation tails. And why does it occur is because the light which is reaching the deeper levels, it is coming after passing through the superficial plexuses, and therefore the superficial networks will have an effect on the deeper slabs. So how do you take care of it? And prior to that, so most of these projection artifacts will be seen at surfaces where there is a lot of reflectivity of the light. So RP being a very reflective area, reflective layer, so most of the artifacts which are seen, projection artifacts, are seen at the level of RP or the choriocapillaries. Now, how do you take care of the projection artifacts? So traditionally the machines used to have slab subtraction. That means the slab, which is, if you see there is a projection artifact in this image, you have the superficial vessels which are network which is projected in the choriocapillaries. You don't expect this network in the choriocapillaries. You have a abnormal vascularization, but this network is projected from the superficial network. So either you can subtract the superficial network from the from the choriocapillary slab, and that will give you only the macular neovascularization, but that reduces the signal intensity of the image. So what is more commonly done is a projection artifact removal software that is incorporated in majority of the machines, in which you see here, this is the superficial plexus which is seen, and then you have the deep plexus in which the superficial plexus has been projected. Now this imaging has been done without the projection artifact removal software on, but when you turn the software on, there is an option in majority of the machines where you can switch on the projection artifact software, and then you can see here that on the left you have a projection artifact removed deep capillary plexus, on the right you have a deep capillary plexus where the projection artifact from the superficial plexus is there. Next is the segmentation artifact. It's very important that you know how to what the segmentation of the machine is, because the machines will automatically segment based on the parameters that it considers from the healthy individuals. But when there is a distortion in the retinal anatomy, the same segmentation parameters or landmarks will not apply to the diseased eye. So if you see in this image, there is some abnormality, there is a neovascularization which is there in the choriocapillaries in the sub-RP level, but because of the bump, if you see the green lines which are of the, which denotes the slab of the deep plexus, you see that is going above this hump, going through the hump, and adjacent, as the yellow area shows, it is going in the pre-retinal area. So because of that pre-retinal area, you're getting a flow void in the middle picture over here. This is the flow void that is happening because of the slab going anterior to the retina. And in the area of the neovascularization, the slab is going posteriorly into the neovascularization, and therefore some abnormality is coming in the deep plexus, but that doesn't mean that there is some neovascularization within the retina in the deep plexus. It is actually in the choriocapillaries beneath the RP. So you can manually, actually the segmentation should be along the pink lines that are shown, but the machine is not able to do that because of the distorted anatomy. And so you can manually change the segmentation, the inner and the outer layers, and then look for the abnormality appropriately. Now shadow artifacts, as I told, it's the last artifact that in this image you can misinterpret it as a flow void, but when you see the signal intensity, you know that the signal is already lost. So in the B-scan image, you see there is a lot of edema. That's why the signals are lost and it's not the flow void. And another example in which you see that there are different flow voids which are seen in the choriocapillaris slab, but when you see the fundus image and the OCT image, you know that there are a lot of drusen's which are there, and therefore it's a shadow artifact which is occurring. Now, OCTA quantification, briefly about it, that you have the option of measuring the vessel density and perfusion density, which are available within the most of the machines nowadays. Vessel density is the length of the perfused vasculature per unit area, whereas perfusion density is the area of perfused vasculature per unit area. And you can quantify this according to different zones in the grid. Then you have an option of measuring the FAS, that is foveal avascular zone. You can measure the diameter, the circularity index. These are also available in majority of the machines. You can use these images to manually threshold them using ImageJ softwares, or you can use other software such as Octava and AngioTool as well. Now coming to the last slide, conclusion. There are certain limitations of angiography, that is the field of view is often limited. There are artifacts, commonly projection artifacts can lead to false impression of the vasculature, and vascular structures which have very low flow such as microaneurysm polyps, they are not very imaged well because they need a very long interscan time, and that is not possible. And you cannot fully differentiate between a leaky abnormal vessel, active leaky abnormal vessel, and a non-leaky anomalous vessel, other than certain characteristic appearance such as a dead tree or a medusa head, but you cannot definitely tell whether they are leaky or not, unlike in fluorescein angiography. And also in inflammatory disorders, you cannot tell about the vascular leakage, which is of very importance in uveitis. And last, you cannot comment on the transit time, which is again important in vascular occlusions. Thank you.
Thank you, Dr. Devesh. Excellent presentation. I'll just like to ask you that at RP Center, you have got access to almost all kind of machines. So which one will you say gives the segmentation error the most, and which one you feel has the least amount of segmentation errors?
No, as Dr. Vinod had already told, segmentation errors will occur in all, and you need to sit down and manually segment them. So I have not noticed any difference in the segmentation errors that occur with a particular machine, but I would like to have the opinion of the panelists as well, other panelists.
Yeah, I think it will happen with all. It's important, and they will happen more when you have abnormal anatomy. So normal retina, they all will do a good job, but once you have abnormal retinal architecture, all of them will make mistakes, and that is where the role of clinician comes in.